Hello. Professor Dr. Latifa Berrezouga from the University of Monastir, the dental faculty. I'm teaching medical microbiology and immunology. And I'm practicing endodontics, dental traumatology, and oral medicine. So I'm a member of the International Institute of Dental Traumatology. And I'm also the secretary of the African Middle East region of the International Institute for and Craniofacial Research. I'm a gold member of the endodontics founded by Professor Dr. Ahmed Madarati, and I'm also a member of the Network General Club regarding antibiotic stewardship founded by Dr. Wendy Thompson. If you want to know more about my clinical and basic research, you can find me in the ResearchGate platform. Otherwise, I'm in different social media. So if you plan to visit Tunisia, so here are so many different beautiful places. Welcome to my country in Tunisia. And I'd like also to thank Dr. Mazen Domani, founder of the Dentistry Online platform, for this kind invitation. And congratulations for diffusing knowledge through several social platforms like Facebook, Instagram, and the YouTube channel. My conference will not be a conventional course, of course, of dental traumatic injuries. It will be an overview of what I'm doing in the management of traumatic dental injuries. I recommend you to visit the website of the International Institute for Dental Traumatology and have a free access to guidelines regarding fractures, luxation, permanent teeth, and injuries in the primary dentition. And you have also different languages of these guidelines in Arabic language, if you are interested, of course. So just to summarize, dental traumatic injuries could be benign, but also severe. They interest the enamel part of the tooth and the crown, enamel and dentin. They also interest the radicular portion of the tooth, and they may be complicated, involving both the corner and radicular part of the tooth. So we may have crack of the enamel, or we may have a fracture, for example, here of the enamel and the dentin, without the pulp exposure, what we call non-complicated crown fracture. So we have to refer to the classification of the International Institute of Dental Traumatology. Here, an example of pulp exposure after enamel and dental fracture. We can have severe trauma, like here, extrusive luxation, for example, displacement and avulsion. And here we have an example of coronal radicular fracture. Regarding radicular fractures, you have several types from the cervical location, well, different types of prognosis. It depends on the level of the radicular fracture. Here in the middle part of the root, it's an intrabony fracture. And here in the apical part of the root, which is intrabony fracture, and the prognosis is better than the cervical part. So we may have also complications due to late consultation or delayed diagnosis. Here, for example, we have displacement of the radicular part of this incisor with this resolution lesion. And here also we have what looks like to a radicular resorption of the tooth. This is a complication, an inflammatory complication of the traumatic dental injury. So I present my study regarding 70 patients with 116 traumatic dental injuries, and I have retained 61 injured teeth because I was interested in investigating the endodontic treatment outcome of traumatic dental injuries involving some variables like age, gender, the time of consultation, the tooth involved, the trauma type, the pulp stages at the time of trauma, the presence or not of apical periodontitis, the number of sessions of treatments, of course, the filler material used for root canal treatment, and the follow-up period. So compared to the literature, of course, maxillocentric incisors are the most implicated teeth. Here we have 87% of the cases, and that's frequently trauma may happen in the incisor and other teeth like canine or premolars. So the patients are young with a sex ratio of male to female of 1.25. And the most important cause, slightly more than 50% of the cases are represented by falls. But here you note that unknown causes also are frequently reported. So regarding the time of consultation, there are really only in 11% of the cases patients may consult in a time less than 30 minutes. But you see here, nearly 56% of the patients consult over 1 year and even after several years. That's why we see patients at a late stage with secular displacement of the teeth, apical periodontitis, here displacement of the radicular portion and resorptions and infections. So it's more difficult to treat complications when the patient consults at a late stage. So regarding the pulp status, also consequently, of course, of the consultation of the late stage of consultation, we have severe symptoms and emergency like irreversible pulpitis and acute apical abscess, alveolar abscess. In nearly 80% of the cases, and most commonly we have chronic apical periodontitis, and with high frequency of apical periodontitis, well, 42% of the cases. Well, large lesions, we have a PIA of 5, which is very important, very large lesions. So concerning the number of teeth involved by trauma, most commonly we have one tooth which is involved by the injury in 58% of the cases, but we may have 2 teeth involved here in nearly 28% of the cases, and rarely we may have 3 or more teeth involved by the trauma. And concerning the type of trauma, we have in 25% of the cases what we call complicated coronal fracture. That means that we have a coronal fracture with pulp exposure. But we have also luxations, radicular fractures, and avulsion. So the number of sessions will depend on the type of the trauma and the severity of the trauma and the presence or not of apical periodontitis and other types of complications. So most treatments were performed in 2 sessions in 57% of the cases, but in some situations we have several sessions that it's not really good to maintain teeth with several sessions of other complications may happen, such fracture of the tooth. So I think that with advancement in technology regarding methods of irrigation and disinfection, we may increase the prognosis of traumatic dental injuries, because here have an outcome at 4 years of nearly 87%, even if compared to the literature, but I think we may improve this prognosis. And the poor prognosis is mainly seen with the severity of trauma. There's a relation between the prognosis and the severity of the trauma. So severe trauma have poorer prognosis than trauma which is not severe and with less complications. So regarding the filling material, it depends on the infection of the root canal, the presence or not of an open apex, of a wide space here, powerful space. And if you have an open, a closed apex, you may fill the root canal with gutta-percha. Otherwise, if you have an open apex, we may obturate with, for example, MTA. And to reinforce, for example, the coronal part, we may use a fiber post. So this study was published in the IHR database during the meeting of the Tunisian IHR meeting, and we'll present you some clinical situations, various situations of management of traumatic dental injuries. And generally, when you have a traumatic dental injury, you have to, of course, first listen to the patient and rule out any emergency, life-threatening emergency, of course, because we have to treat patients. We perform a chairside treatment, or we have to refer the patient to the hospital. It depends on the severity of the condition. But we have to perform an acute clinical examination and radiological examination, and to plan to make a plan, of course, a clear plan, to make understand the patient, the treatment and the outcome of the treatment before any initiation of the treatment, of course. So this is a first example of a young schoolgirl. She's practicing Taekwondo and unfortunately with no mouth guard. And she got the direct shock on her tooth, the center incisor, the right center incisor. And fortunately, she came with her mother with the fragment of the tooth, and just to have reposition of the fragment while using resin composite. And I got the chance to see the patient frequently with routine control, clinical and regular control. And after 70 years, the fragment is still here, and with no complication, no radiological complication. I'm sorry, I don't know if you see the apex and the periapical region, but I have a similar, similar aspect of this radiograph when we compare to the initial one. That's it. So you see here after 17 years. So we have the vitality testing is positive. And that's it. And the patient became a young lady with her children. So this is the second case. I had to be careful in the situation and not to do systematically root canal treatment. So we have to wait and see, because when you see patient coming to the consultation, I guess this is extrusive luxation of the left central incisor. The clinical appearance here with this bleeding from the gingiva and from the socket, because the tooth is mobile. And it's not really obvious to do vitality testing, you know, but when you do this radiograph and you have really to make the interpretation of this retroviral radiograph, when you see the crown, you have no pulp space here, and you have a very narrow radicular pulp space. So I'm not really sure. It's not due to the trauma, you know, the patient consulted 13 minutes after the trauma. It's an early consultation, but I have just to ask the patient if he had the history of a trauma when he was young. And certainly he has a trauma in his primary teeth that had an impact on the pulp reduction here, reduction of the pulp volume. So be careful. We have no clear the discoloration of the center incisor. It's not really obvious to have the vitality testing. So we have to reduce and to splint. At that time, I have a nylon fish line, and I have so used, of course, fixed the splint with composite resin. And which is very important here is to control the patient. This is after 1 year. So everything is okay clinically and geographically, and you see the graphical region. There is no symptoms, and look to the center incisor and compare to the to the adjacent tooth. And this is after 1 year. There's healing on the graphical region. So we have not really to perform root canal treatment, because we have a narrow space of the pulp of the dental pulp. So this is another also type of traumatic dental injuries occurring in a man, in a young man of 20 years old. This man has an apex and a closed apex, and he presented early with an extrusive luxation and intraalveolar fracture of the bone, and also a radicular fracture. So you have just to reduce the fracture and to splint. And after splinting, of course, we give advices to patients for the control, to be aware of the influence of the control, etc. But the patient didn't show up. And I've seen the patient after 1 year. There is no splinting here, but remnants of composite resin. So when I did the retroviral radiograph, I have noted that there's healing of the lesion, of the trauma, and the pulp was vital. So I did the publication of this situation, because the healing was favorable. This fracture at the intrabony fracture, and at the pulp is the space is relatively important. There was a revascularization okay, of the pulp. This is really interesting when you have the type of fracture at the midroot and a intrabony fracture. So this is the publication of the Journal of Dental Traumatology. So another situation in a young woman, 70-year-old, but this patient consulted for aesthetic issue, the discovery of resin composite here, and morphology, which is different of the left center incisor when you compare to the right incisor, and in the radiograph, so diagnose a lacerated central incisor because the patient had a history of trauma and her primary teeth, and that's why there was laceration and maybe necrosis also of the dental pulp. So, and the root canal treatment was inadequate. I retreated the canal, and I had used in this situation fibers, polyethylene fibers, to as in fact additional retention for the coronal restoration with composite resin. So another also situation of delayed consultation in a patient with displaced incisors and who had a luxation, a history of luxation, and with pulp necrosis and chronic apical periodontitis and an open apex. At that time, we haven't MTA or biodontin, so I did apexification using calcium hydroxide till the formation of this calcified barrier, and we have just to fit, get up a sharp point, and then obturate. And after 2 years, we have the healing of the lesion, and the patient got her orthodontic treatment. Well, this also a different situation of an acute apical abscess with a large lesion related to the left central incisor with an important volume of the pulp space and an open apex. So it's not difficult to drain this abscess from the coronal part. And what I did at that time, I used the bleeding technique for endodontic regeneration. So after that, I see the patient in a second session, and I have noticed that I have a calcified tissue here in the apical portion, asymptomatic lesion and tooth, negative percussion, and of course asymptomatic tooth. And I filled the canal with MTA till the calcified apical portion. And unfortunately, the patient didn't show up at the time when I seen him for the last time. He was asymptomatic. Yeah, I was curious really to see the, of course, the healing of the lesion. Unfortunately, I have no idea about the outcome. So this young girl of 10 years was referred for a coronal fracture. That fracture line is invaded by, of course, the proliferation of gingiva here. And when you took a alveolar radiograph, you see here the structural line. And with no displacement, there was no mobility of the tooth. So I did the root canal filling, And then under magnification, this is very important for magnification here, because you have to see very well the end of the this radical fracture with the later resorption of the alveolar bow. And I have here some fracture line with composite resin, what you see here. And I have no periodontal pocket. This is very important to check for periodontal pocket each time you have an injured tooth. And even if the patient was victim of a second trauma and presented with an alveolar abscess, I'm sorry, I have no image here, but when you took the retroalveolar radiograph, you have this lesion, important lesion. You have not really to attach to the root canal film. You have just to drain the abscess and to control the, and you have a significant increase of the lesion here. So I have some cases, in fact, in the posted in the Excellence in Ethics group in Facebook, and one of the cases is an estimation, you know, because it's difficult to diagnose what we call particular fractures. So this mimic an apical periodontitis and abscess with apical periodontitis. This is a draining fistula. And this person, and young adult person, with this corner fracture, discolored crown with several cracks and an open, in fact, here you see the canal. And I have, of course, we have to check for periodontal pockets. So there's no periodontal pocket at problem. And I have traced the fistula, the draining fistula by a gutta point. And the patient is a teacher, and he was presented for an aesthetic emergency. I did the check because I have considered it's a necrosed part with a small periapical lesion, and I did a bleaching session and applied composite resin. That resin. After 5 years, the patient presented with nearly the same size of the apical periodontitis. You know, that I'm speaking. No, this is the initial one, sorry. But after 5 years, look at the evolution of the radiolucency here and the periodontal, deep periodontal pocket extending to the apex. So the diagnosis was obvious. And I have traced this time in fact, the lesion, the periodontal pocket, with good aperture, because the draining fistula was not opened here. Okay, so I put the good aperture point into the pocket. Okay, so after extraction, I see the radicular fracture here, and I did scan an electron microscope that reveals the fracture from the apex associated to this apical lesion, chronic apical lesion, and this fracture is extending along till the root, till the crown part. The crown part is I remind you that I did the composite resin of the crown, the construction. So it's really difficult to diagnose, but I think we should suspect articular fracture of the apex when we see all these cracks. This is really a rare and difficult diagnosis. So when you see the apical lesion with greater magnification, this is a preapical lesion surrounded by fibrous tissue, and with greater magnification, we see the biofilm. The biofilm made up of bacteria and cells and debris and complex, in fact, biofilm attached to the root of the canal. So let's move to severe dental trauma. This is a schoolboy of 9-year-old, victim of a fall in a swimming pool with water slides. So the trauma was severe because he lost his 2 central incisors. And look at the injury here at the exam. And we have to rule out efficiency, holes, to have extensive bleeding or serious lesion. We have to contact, of course, surgeons or maxillofacial surgeons. So at clinical examination, you see the fracture of the bone and several types of the fracture of the alveolar bone. We attempt to reposition the bone to have the 2 sockets that will in which we will in fact reimplant the incisors, and we did a retroviral radiograph here to make sure that we have no foreign body objects. And after that, we performed the sutures of the injured mucosa, and we have used the center incisor, the replaced center incisor, and we made the spring to allow, in fact, the bone to heal. And we did, just after the intervention, panoramic radiograph to make sure that we have replanted in a well position the center incisor, and we controlled the patient. After 7 months, the outcome was really favorable, and you see here in the CBCT in sagittal view, we have still the roots of the center incisors, of course, with an open apex, but importantly, as we have seen the patient during the COVID-19 pandemic, we lost the patient, and he showed up after 3 years. And in fact, I had contacted my colleagues of pediatric dentists to try to manage several problems related to mouth breathing, extensive resorption of the roots, dental gap, malocclusion, and the situation, of course, of the labial frenum here. So this patient is still under treatments and control. Another type of severe situation here is a young patient victim of a car accident. Be careful, because we have to keep calm and comfortable with patients when they present. They may be shocked, and not only the patient, but even members of their family may be shocked, and we have to keep calm the patient and to be patient and to speak with the patient and try to understand concerns, because the patient was really afraid to teeth, and it's really a great aesthetic concern for her. So when I asked her to open the mouth, she just opened that way. That I asked her to be cooperative, to understand treatment outcomes, to understand the outcome of the treatment and to be cooperative. This is very important, and the patient, I think, understands the treatment outcome, and she opens better the mouth, and I explained that I can make the intervention under local anesthesia, of course, not to have pain. At first examination, you see the impact of the shock. The patient was sitting near the driver during the car accident, and I asked her if she is wearing the seating belt, and the response was negative. So she got the shock, and she hit the interior mirror of the car. So she got the fracture of the alveolar bone and the laxation, the palatal laxation of the central incisors. But fortunately, there is no radicular fracture of the incisors, but fracture of the lateral incisor. And I succeeded to, in fact, reduce the center incisors, and I secured the lesion, and we did the splinting after that, and we controlled the patient after after 1 month here. Yeah, I didn't speak about, of course, the duration of splinting. It will depend on the severity of the trauma. When you have a laxation, which is not severe and not associated with a radicular fracture, we may have just a splinting of 7 days or 10 days, or we have association of, if we have an association of alveolar bone fracture, we may extend the splinting to 1 month till 45 days. So the patient just after a couple of months, and we will see the patient in a few weeks to control clinically and radiographically if everything is okay, if there's no symptoms, and make sure that there is no dental path necrosis. So the last situation, and the most complex situation, and somehow complicated situation, because we have an injury of 7 teeth at the same time in a 40-year-old schoolboy who was victim of an aggression by a stone by another schoolboy, and the patient presented nearly 60 minutes after the trauma, and he had complicated crown fracture of 3 teeth, the right incisor, the mandibular incisor, and the canine, and 3 avulsion, the lateral incisor, the central incisor, the lateral incisor, the central incisor, the lateral incisor of the canine, and he had another slight trauma of enamel and dentin loss. It's a minor trauma in another central incisor of tooth 41. So the splinting was done in another department. So I have received the patient. I did orbital radiographs, and you see here the available fracture, and this is the available fracture, and this is the apical fracture in the maxillary canine, which was replanted. And I guess the maxillary canine was replanted while the apex was in the socket. Okay. Um, so what I did is the root canal filling of the tooth with complicated crown fractures that it took a lot of time, and the patient presented with a complication related to a burst of teeth. This is an abscess, and we may guess that we have complications related to avulsed replanted teeth, and these complications are inflammatory resorption of the root of the central lateral incisor with apical resorption. And apical resorption here, look at the displacement of the apical fragment here of the canine, and the resorption of the root here. And you see the cross part. So what I did at that time is the dressing of the canals of the three with calcium hydroxide to arrest the resorption. In fact, you see here the arrest of the resorption, and I did the fillings of the three teeth. So the prognosis was very good, and I finished by reconstruction of the fractured crowns with composite resin using polyethylene fibers for retention, and it works really very, very well. So this is the final situation immediately after treatment. This is the situation after 2.5 years with slight infra-occlusion here. Okay. And I got the chance also to follow the patient at 2.5 years. These are radiographs after control for follow-up, and look at this canine with two roots. And I published that case after 2.5 years in the Journal of Dental Traumatology. And one of the explanation, in fact, here is that probably, according to Galileo Galilei, that objects accelerate and gain in speed, and here it depends on the distance. And well, when we increase the distance, we have the plate is broken, in fact. So I guess that the child, when he throw the stone at given distance, at the object accelerate and gain in speed, we have 7 traumatized teeth. It's one of the explanation I have found. So I've seen the patient 8 years later, and if you compare to the central incisor, the right central incisor, which is only concerned by the crown fracture, and this is the avulsed teeth, the 3 avulsed teeth. Here we see that the root is intact, and here we see the replacement absorption of the left center incisor, which is extended here in the lateral incisor, where this radiolucency more extended in the canal, while this radiolucency. So 8 years later, there's no mobility, and we have just to follow the patient until you'll have the opportunity to for prosthesis. final restorations. But 15 years later, the process and even 17 years later. So I've seen the patient at age 14 years, and he's a dad now at the age of 31 years old. This is really a happy end for the patient. And to finish, I just want to summarize that traumatic dental injuries are various, and there's a very diversity, and management is not really the same for each type of traumatic dental injuries. And we have to take the time to make understand the patient that treatment can be challenging, and which is very important that the patient will understand the outcome and will be a cooperative patient. This is very important because we need sometimes several sessions and several follow-ups of the patient, because we intend to insert traumatized teeth rather than make extractions and implants. So, and of course, we have to make an accurate clinical and geographic exam and to mainly follow up patients. I just want to pay tribute to Jens Ove Anderson, who is the pioneer of dental traumatology. And you may want to know more about Jens Ove Anderson, about his publications in the website of International of Dental Traumatology. You have all guidelines that are free, access free, and you have also the dental trauma guide. And if you're interested by the symposium, which will be held in Copenhagen in 2023 in October, so it will be very interesting to attend the meeting. And finally, I want to inform you that currently there's the 7th online conference in the Excellence in Endodontics group during July and August 2023. You may attend very, very interesting online endodontic conferences. And just the 2019 pandemic, I think, period raised the awareness about health and sport, and I hope that you stay healthy. This is very important. And I show you just examples of my drawings and paintings. And I want to thank again, of course, Dr. Domani for this kind invitation. And I invite you, if you have questions about dental injuries, and I hope that you have learned a bit about traumatic dental injuries. I have stated initially, it's not really a course, it's just an overview of what I'm doing in traumatic dental injuries. And I'm really thankful. Thank you very much. Bye-bye.